Hey team, let's take a look at an area of PT that I don't think we always give enough attention, and it's GI conditions. So let's find out what can go wrong with this very important series of organs. We're covering quite a few conditions today, and a lot of what we're going to be doing is looking at things that are specific for a PT and having a basic understanding of these conditions. Some of them might not have a whole lot of content, and that's okay. What we really need to do is make sure we're focusing on things like positional symptoms, referral pain patterns, and things that are really allowing us to be good screeners and stewards of our patients. Okay, let's start up at the top. Esophagus. So when we're thinking esophageal disease, there's some things that are kind of more indicative that something is wrong, specifically in the GI tract at the level of the esophagus. So one can be issues with eating, right? Kind of get everything swallowing and going down. So the feeling of, I feel like I'm getting food stuck in my throat. That means we might need to do some screening. Next is going to be heartburn, which makes sense. Any sort of vomiting of blood. And there's two ways in which we tend to have issues with that. So one is bright red blood if the bleeding is occurring at the level of the esophagus. And then maybe if something's happening a little further down in the stomach, a little bit of digestion occurs, and so the blood can appear darker in color. And then sometimes the issue is happening in the esophagus, but it's not coming up. It's actually getting all the way through the GI tract and getting excreted. When that happens, we have a phenomenon called melena. Melena is where feces have a dark color, and it's because they have blood in them. There's also a pretty iconic smell presentation for melena. It's kind of that rusty smell. You really can't miss it. It honestly smells like blood, as well as the texture of the feces can be different as well. Okay, first condition, hiatal hernia. With hiatal hernia, we're thinking this is older adults, right? And with this is an anatomical issue. It's the protrusion of the stomach above the diaphragm. So in this status, we would call it the fundus. So you can have different types of hernia, and it's slightly more common in women than men. We're talking about kind of a preference for a different group for the sexes. But really what we want to focus on, yes, incidence is important. We do want to know this is an older adult condition, but I think the presentation is really important here because sometimes, especially with GI conditions, our patients can kind of explain away things for a little bit at the beginning of something getting symptomatic, and that delay in going back to see your PCP can cause a lot more issues down the road. So let's think about presentation here. Heartburn, sternal pain, difficulty or painful swallowing, and then there might be some sort of like ulceration in the mucosa back in the esophagus, and this is from stomach acids getting kind of pushed up, as well as any sort of bleeding type issues. So a hiatal hernia. We can have issues with secondary pathologic events that get noticed more often. So what we're thinking here is that the mucosa lining the esophagus and stomach get irritated, and that pockets food and a lot of acid, and that's usually what's causing more of what we're seeing. So what do they do for this? Well, they can go in and surgically work on this, but a lot of what they'll look at actually treatment-wise is symptomatic control. PT implications here are kind of interesting. They really shouldn't lay flat, ever, and this is to manage the location of acid. We don't want that up in the esophagus. It doesn't belong there. It's going to damage and irritate the esophagus, so we don't even want to go there, as we'll see with some conditions coming up here. So we want to keep acid where it belongs, which is in the stomach. Therefore, these folks, it's not a good idea for them to lay flat. That includes during sleeping or when they're in treatment. And they also need to avoid anything that involves the Valsalva maneuver. In layman's terms, we sometimes call that bearing down and doing kind of a huh sort of sound. So that should also be avoided during PT intervention anytime you have a patient with a known diagnosis of hiatal hernia. Mallory-Weiss syndrome. So I usually hear this one with the V sound for the W if you're worried about sounding like you've heard of it before in clinic. So with this is a laceration at the GE junction, so where the stomach meets the esophagus. Usually this is a presentation that we find with individuals where there's a lot of acid occurring in that area. So in other words, that's somebody who vomits a lot. So somebody with a chronic ETOH abuse condition or somebody with an eating disorder, as well as those, honestly, you can have an acute illness that causes enough vomiting to create some level of Mallory-Weiss going on. Or it can be a couple incidents with really, really violent vomiting. So you can see in the image there that there's a little bit of almost a tear there along where the esophagus meets the stomach. So the presentation matches with that. You can have GI bleeding, so they can, excrete the blood, they can vomit it up, and a lot of lower chest pain. It's lower than you would think for what it is. So it's not going to be up high, like towards the throat. It's going to be a little bit lower onto the sternum. What do they do for this? They really try hard to get rid of whatever the source is. Otherwise, you try to manage it so that the injuries, the laceration can heal. This is dangerous stuff. It's extraordinarily painful too, every time you swallow, right? Another condition, esophageal varices. This one has a strange pathophysiology. Let's get into it by identifying the etiology. So know that this is almost entirely a condition that we see in patients with a liver condition, so a cirrhosis condition. And the etiology itself is from dilated vessels, which become called varices, in the plexus of veins around the esophagus. So what we're seeing are dilated veins in the lower portion of the veins that surround the esophagus, so the lower 1/3. The presentation here is kind of strange. So if you have enough issue in that area, in other words, enough dilation of those veins, they'll rupture. And when that happens, this individual might be vomiting blood, okay? So we really, really don't want, I'm going to say this right off the bat, we do not want any indication that a person has ruptured veins at the level of the esophagus. This can become life-threatening levels of blood loss. In its less aggressive or less progressed forms, you can see that the person begins to swallow the blood and digest it. And that's when you end up with these thick, black, tarry stools. If they're having enough blood loss, they usually have some element of lightheadedness. In these severe cases in which there's a massive hemorrhage, they're likely to pass out or have a syncopal episode. And then because it's kind of uncommon for esophageal varices to happen on their own, in other words, the liver is almost always involved at the same time, they will also have symptoms of liver disease. And the classic signs and symptoms, easy bleeding, easy bruising, swelling that's kind of whole body, and the iconic jaundice. Esophageal varices, again, are observed right here with the purple along the representation of the esophagus here. So what happens is that you have this anatomic source. The veins from the esophagus, just south of them, are actually connected back to the portal vein. So if there's issues happening in the liver, in other words, if it has a cirrhosis status, then you're getting obstructive blood flow from the swelling and dysfunction of the liver to the portal vein. Again, remember that the portal vein carries blood from a lot of different organs down so that it can get processed, right? So anytime there's liver problems, it tends to manifest sometimes with the esophagus. So that's the weird pathophysiology here. It's almost an anatomic thing. Just by chance, it's kind of strange, but just by chance, the veins of the esophagus have a relationship, an anatomic relationship with the veins of the liver. And so that's why liver dysfunction can lead to esophageal varices. So unfortunately, a lot of times by the time we notice this, there's another issue happening. So be aware of that, okay? Another thing to consider is that the burst of those varices can lead to death in 1 in 5 to 1 in 3 patients. So if they get to that status, that is such a hard red flag. My goodness. I mean, it goes without saying that if somebody is vomiting up blood, they should go to the emergency room, but you'd be surprised how many people kind of don't take that with the gravity that they should, and they explain it away. It's surreal, but it is a thing. Unfortunately, even in somebody who maybe does manage things well, rebleeding is really likely. So just be aware of that, okay? Because the hemorrhage can be so profound in this area. So esophageal varices, if you see it on the chart, that is a surprisingly dangerous condition. Basically because if the rupture happens, the likelihood of death is not small. So what do? Well, they try really hard to resolve the reason that there are varices in the first place. And what's really good is if they can get the liver condition that's probably causing it under control, then the condition can evaporate. It can resolve completely, which is really good. So anything that might cause the varices to rupture, we want to avoid. And some big things that we want to help with that are proper lifting techniques, and then anything that can increase intra-abdominal pressure we want to avoid. So what we're thinking here is, once again, avoidance of the Valsalva maneuver, as well as any sort of techniques that may involve pressure to the abdomen and similar. So that also means like breathing through lifts and all of those things that you think of as just like basic weightlifting safety. This actually applies really importantly, I'd say, to ADL. So in other words, if somebody has a pet or a young child that they tend to pick up, lifting techniques here are important, or they might not be a good option for right now while they have a status of a diagnosis with esophageal varices. GERD, gastroesophageal reflux disease, incredibly common, incredibly common. Let's look at incidence here for just a second. Check this out. So 10% of all adults in the United States have this condition, and the majority of your individuals who are pregnant will have it. And a not small percentage of the population, even just over 40, it surprisingly skews a bit middle-aged, will have GERD. So what is this? It's stomach acid flowing backward into the esophagus, irritating the lining of the esophagus. So normally the acid stays in the stomach. Well, in this condition, it goes a little bit past. So what's the presentation? It's heartburn, especially after eating. And they might notice the heartburn that is worse at night. That tells you that's really positive for GERD, because gravity allows this acid that's maybe right at the edge of the gastroesophageal juncture there to kind of come through if they lay down flat and supine. So if they notice a heartburn that happens specifically when they lay down at night, that's a pretty positive indicator for you need to go see your physician for management of GERD. They might also have chest pain or difficulty swallowing. They might have a little bit of kind of like a pseudo throwing up sort of thing. It's like, it kind of happens, but not all the way to vomiting. And a sensation of having a lump in the throat. Because this makes you uncomfortable because it gives you chest burn, it may mess with their sleeping patterns. Most people instinctively will start propping themselves up, but not everyone does. In other words, they'll sleep on more pillows at night. So this can cause a lot of different injuries to the esophagus, and you can have like direct injuries to the esophagus that cause GERD as well. But for the most part, what we're really worried about is just that a constant state of inflammation is not good for any organ, because over time, the lining made up of endothelial cells get injured from all that acid. So you kind of come back to what's really causing this. It's exactly what you would think, okay? It can be a condition we learned about earlier called a hiatal hernia, which is causing anatomic smushing of structures, right? And that's how the acid refluxes up. Otherwise, you can have a lot of intake of things that tend to cause distress to the stomach, such as smoking, alcohol, fatty foods, and then interestingly, is people who intake a lot of chocolate. So that's what we're worried about with that. And what we're also worried about is that over time, you end up with the bleeding at the level of that juncture there, and eventually a condition called Barrett esophagus, which we'll learn about here in just a minute. What do we do with our patients with a GERD diagnosis? Well, we definitely refer them back. So I would say that a lot of times an indication that your patient has GERD is, and that you don't know right off the bat, is that they take Tums or another over-the-counter drug for heartburn all the time. So the boundary is actually twice a week. If your patient is using an over-the-counter medication like Mylanta, Rolaids, Tums, something like that, more than twice a week, they actually need to be referred back. You might be thinking, oh, I actually know quite a few people where that fits. Yes, you need to refer those people to their PCP. In addition, not only is that a concern for they're not properly managing GERD, those over-the-counter antacids actually are meant to be used long-term. And so you can end up with secondary issues affecting lower in the GI tract, which can result in diarrhea, or you can end up with weird kind of metabolic issues causing some kidney problems. So the thing I say is if anybody you know pops Tums like candy, that needs to go back to the MD for proper management of GERD. What do we educate these folks on? Well, there's a lot of positional things that they need to be aware of. One is that they really shouldn't lay flat until they've digested all the way, and that way their stomach is cleared of acids. So they need to be finishing dinner 3 hours prior to going to bed. So that does mean no late night snacking. They need to avoid or reduce intake of triggering foods, and of course it's everything fun. And then it can be things that you don't necessarily think of as being a concern, such as mint, garlic, onion, tomato sauce, but all of those have a little bit of like an acidic component, and that's part of why they're kind of like, you either need to avoid or reduce intake of those foods, at least to get some of that GERD managed better. And then if they really are having issues and, I ate a meal and now I'm sleepy, I want to sleep, okay, well, you need to elevate the head of the bed 6 to 9 inches, which is actually quite a bit. Often additional pillows aren't enough. You actually need to do the propping by placing something under the mattress. Otherwise, there might be kind of more of an anatomic issue with body habitus, and there might be a good indication for somebody to consider losing weight, or they may need to engage in a smoking cessation program. And you can help encourage them that'll actually help you sleep a lot better. So let's get all the way down to the worst thing. That's Barrett's esophagus. So this is actually a complication of GERD. And unfortunately, Barrett's esophagus, I don't think it's unreasonable to say that it's one step away from cancer to your esophagus. What on earth are you going to do if you have cancer to your esophagus? Very serious surgical interventions is the answer. I used to work on a trauma floor where we had patients with, they send patients with cancer of the esophagus over to the trauma floor. Yeah, so working on a floor that sometimes worked with individuals with TBI, we also sometimes got the folks who are post-op from trying to resection the esophagus for cancer in that region. Why? Because we're used to horrifying things happening to the head and neck. That's the level of seriousness that you're going to interact with. It's all the tubes you can imagine coming out of your jaw and your neck. It's extraordinarily painful. They're not allowed to eat, obviously, so they have to take their digestion in through, surgical methods. This is a terrible diagnosis, but it can get a lot worse if we make it all the way into adenocarcinoma of the esophagus. So all that is to scare you. Yes, I would say this is a condition in which I encourage a wisely applied therapeutic care. GERD gets serious quickly because all of that acid creates metaplasia, causing replacement of the normal mucosa and the epithelium of the esophagus with another cell. And when you replace out those goblet cells, you end up with the wrong type of thing there. So now the esophagus can't protect itself. And anytime we have chronic inflammation or repeated damage to a cell type, eventually the body keeps replacing those cells. You're basically increasing the odds of random genetic mutation. And mutation in that area is how you end up with adenocarcinoma, with cancer. Okay, so that's why you get these little adverts like this kind of loud in your face red, yellow, and white thing here. Acid reflux can lead to Barrett's esophagus, which can eventually lead to cancer. So a status of Barrett's esophagus is basically like the last warning that you need to take your reflux seriously. So who's more likely to get Barrett's? Well, men more than women by a large ratio. And they think there's an epidemiologic reason here. In other words, it is more common for men to abuse alcohol than women, and that's often a lot of times when Barrett's tends to manifest. There's a slight predisposition for whites more than other races, but more so, I think what you need to be aware of is that it's men more than women. Most of the folks I've seen with a Barrett's diagnosis are men. That matches with my clinical practice. So one thing I would say too is that this gets more at like a whole health perspective. If you have a patient with a reflux condition such as GERD and they're taking proton pump inhibitors, so in other words, this class of drugs creates, it's an antacid. So if they're taking alternative medicine options or they're taking herbal things, that still means you refer them back. They don't necessarily have to pop Tums. They might think that taking acid reduces acid. That's a thing culturally. I've had patients tell me, yeah, I take apple cider vinegar for my acid reflux. And I'm like, whoa, where do we learn that? I'm not sure why that's a thing, but it's totally a thing. So one thing I would caution is be culturally sensitive, but also be accurate. Your patient with reflux needs to take proper medications for this. So if they're using alternative options or they're using like herbal remedies, refer that back. Unfortunately, aloe vera isn't going to prevent you from getting cancer of the esophagus, and it's a horrifying prospect to get that. Okay, let's stop here and then we'll jump over to conditions of the stomach.